This video is to show students who are just starting the clinical stream the basic technique of abdominal examination. We position the patient supine with only a thin pillow to make sure that abdominal wall is well relaxed. Patient should be comfortable and there should be good light. We start with a general examination. First, look at the conjunctiva to see whether there is any pallor or polycythemia. Look at the sclera for icterus. Look for any parotid swelling. Look inside the mouth, Katarina. And then examine the neck for any lymphadenopathy. You should examine the neck for lymph nodes from behind. Look for submental lymph nodes, submandibular nodes. Feel down the carotid for the jugular nodes, supraclavicular foci, and then the posterior triangle. You have to palpate deeply between the two heads of sternomastoid for the Virchow's node. Enlargement of the Virchow's node is called the Trousseau's sign. Shift your eyes to the chest. Look at the skin for pigmentation. Look for the distribution of hair. Look for any spider nevi. And feel for painful gynecomastia. They are all signs of chronic liver disease. Sometimes you might notice scratch marks in case of obstructive jaundice. Pick up the hands. There are several physical signs you might be able to see in the hands. Clubbing, white nails, palm erythema, dipitron contractures, and flapping tremors. Presence of flapping tremor indicates liver failure, cardiac failure, or even renal failure. Look at the ankles. Look for any pitting edema and also any chronic ulcers that might indicate chronic hemolytic anemia. When you do the general examination system, the abdominal system, you should look for signs of not only GIT disorder but the signs of chronic liver disorder and signs that indicate hematological problems. For inspection of the abdomen should be very well exposed from the nipple lines at least to the level of the pubis. You walk to the foot end of the bed and then take a look tangentially and also laterally. To facilitate examination, the abdomen is divided into 9 zones. Right hypochondrium, right loin, right iliac fossa, hypogastrium, left iliac fossa, left loin, left hypochondrium, epigastrium, and the umbilical region. During inspection, you look for any masses, any distension. If there is any distension, see whether the distension is in the flanks, like for example in ascites, or whether the distension is limited to one particular region. For example, any fullness in the left hypochondrial region might indicate splenomegaly. Look at the umbilicus and see whether it is everted or inverted. Look for any surgical scars. and see whether there are any distended veins which might indicate the obstruction either to the IVC or to the portal vein. The next step in the abdominal examination is a palpation. We start by doing a light palpation. First you ask the person whether there is any pain, and if so, you start well away from any area of pain or tenderness. You make sure the forearm is horizontal and you do very light dipping movements. Once you start, the hand should be in constant contact with the abdomen. And keep on looking at the patient's face to see whether there is any indication of pain or tenderness. Make sure you palpate all 9 zones. To palpate for any possible hepatomegaly, first you keep the fingers just lateral to the rectus muscle below the costal margin. You apply firm pressure inwards and upwards and hold the hand steady. Then ask the patient to take some deep breaths. You keep the hand steady, and during inspiration you will feel the edge of the liver rolling under your fingers. If the liver is enlarged, you follow the edge medially. And measure the enlargement in the mid-clavicular line, and then feel the surface for tenderness, the regularity. You have to percuss for the upper border to see whether the liver is really enlarged or just pushed down. You feel for the gallbladder at the tip of the 9th rib. You just keep a finger firmly, and if there's any gallbladder inflammation, during inspiration the patient will feel pain. හොඳට හුස්මක් ගන්න. එළියට දාන්න. ආයෙත් හුස්මක් ගන්න. රිදෙනවද? නෑ. One pitfall you should be aware of is that if you start too close to the costal margin, you might miss the enlarged liver. Spleen is in the left hypochondrium between the 9th and 11th ribs with its anterior margin in the mid-axillary line. When it enlarges diagonally towards the right iliac fossa. When you feel for the spleen, first you keep your fingertips of the right hand just beneath the left costal margin. To palpate for the spleen, you keep your right hand below the left costal margin and apply steady pressure upwards and inwards. Ask the patient to deep breathe, and during inspiration see whether you can feel the tip of the spleen. හොඳට හුස්ම ගන්න ගාමිනී. ආයිත් ඉහළට එළියට දාන්න. Right? If you can't feel the tip of the spleen, you inch your way upwards till you feel it. හොඳට හුස්ම ගන්න. එළියට දාන්න. Right? හොඳට හුස්මක් ගන්න. If you can't feel the tip of the spleen just beneath the left costal margin, you have to turn the patient on the right lateral position. මේ පැත්තට හැරෙන්න. His left hip and the left knee should be flexed. මෙහෙම තියාගෙන ඉන්න. There's one point you have to be cautious about. If you start too close to the left costal margin, you might miss a hugely enlarged spleen. So in certain situations, you may have to start feeling in the right iliac fossa and then move across the midline diagonally towards the left costal margin. If you find a mass here, which you think is a splenic mass, see whether you can feel the characteristic notch. There are certain other characteristics of a splenic mass. For example, it moves diagonally across the midline, moves with respiration, it is dull over the lump and there's no band of resonance, and the dullness continues with the normal splenic dullness. You cannot get above the lump. You use the bimanual technique to palpate for any renal masses. Left hand is placed posteriorly and the right hand anteriorly, the left loin. You bring two hands together firmly but gently. You ask the patient to breathe slowly in and out and see whether you can feel the moving kidney mass between the two hands. හොඳට හුස්ම ගන්න. ආයිත් If you find a renal mass, you can confirm it by using the technique called ballotment. In this, you ballot the kidney or a possible renal mass with your left hand and see whether the mass comes and hits the anteriorly placed hand. Once you finish palpating the left kidney, you repeat the procedure on the right side. First you bimanually palpate the kidney and then ballot if there are any lumps. After inspection and palpation, the third step is the percussion. There are two important points that you should keep in mind about the percussion. First, you always percuss from resonance to dullness, never from dullness to resonance. The second point is the percussing finger should be always parallel to the border where you expect the dullness. For example, if the border of dullness is like this, your percussing finger should go parallel to that. When you percuss, only one finger should be touching the abdomen, and you percuss on the middle phalanx, and the percussing finger should hit that finger at right angles. The movement occurs at the wrist joint. First you elicit the flank dullness. When there is ascites, fluid tends to gravitate towards the flank and the bowel containing air tends to float in the center. Percuss parallel to that border and move laterally to see whether there is any dullness. If there is any dullness, then you look for shifting dullness. If you find an area in the flank when the dullness first appears, you keep the finger without moving and get the person to roll over to the opposite side. කාමිනී පොඩ්ඩක් හැරෙන්න මේ පැත්තට. See whether that area that was earlier dull, whether it has now become resonant. If there's a lot of free fluid in the peritoneal cavity, not only the flanks, but even the hypogastrium will be dull. That dullness is called horseshoe-shaped dullness. To demonstrate the horseshoe-shaped dullness, you start percussing in the epigastrium and again go parallel to the expected border of the dullness. In a patient with gross ascites, the whole abdomen will be distended and you will be able to elicit the fluid thrill. To elicit the fluid thrill, you can ask the patient first to keep his hand in the midline. Then you tap on one side and see whether you can feel the thrill, the fluid thrill here on your opposite hand. Presence of fluid thrill indicates gross ascites, and the absence of fluid thrill does not mean that there is no free fluid in the abdomen. The reason for asking the patient to keep the hand here is to prevent the thrill being conducted across the abdominal wall to the opposite side. When the hand is placed, the thrill that is conducted through fluid. The last step in the examination of abdomen is auscultation. There are few things in the abdomen that you auscultate for. You have to listen to the bowel sounds, and the position for that is just below and to the left of the umbilicus. See whether the bowel sounds are increased or whether they are absent. You listen for a renal bruit at a point halfway between the umbilicus and the siphisternum, about 2 centimeters lateral on either side of the midline. You hold the stethoscope and listen carefully for a possible renal bruit. If the spleen or the liver are enlarged, you ought to listen over these organs for 2 things. One is a bruit, the other one is for a rub. When you listen for a rub, you ask the patient to breathe in and out quietly. To listen for a bruit, you have to ask the patient to hold the breath. Bruit could be very soft and it could easily be missed. Examination of the abdomen is not complete unless you examine the hernial orifices and external genitalia. Where relevant, you should perform a rectal and vaginal examination as well. You should be very gentle with your technique and make sure that patient is comfortable throughout the examination. As Gamini is a volunteer, I did not